Hello and welcome to CNBC Africa's special broadcast of the Future of Health Summit held by Forbes Africa in conjunction with Philips Health in Abuja, Nigeria. Many thanks to you for joining us.
This is the second time we've heard it. We've had this conference in Nigeria. The first time was in Lagos. This is the first time in Abuja. Thank you very much for welcoming us. And also, we've also reached out to Kenya as well in the interests of the furtherance of the future of health on this continent, which in my view as a journalist is one of the big stories I think this continent faces. We've got massive population growth. We have infrastructure that's groaning under the weight. We have government coffers that often are empty. That's something I hope to tackle the health minister on a little bit later in this program. But what we'll be talking about here is some of the hot issues of health. We'll be talking about mother and child issues straight up. We'll be also talking about investment and how perhaps we can bring private money into the health industry here, which obviously from a business point of view, we're very interested in that. We'll be also looking for the wow factor in this, in the fact that we'll be getting people to talk about new innovations that not only here, but the ones that are coming tomorrow, the ones that excite the industry, the ones that could change the game completely, the ones that could save lives across this continent. And I think that to me is the thing that we should be watching out for today. So let's start out with a overview of Nigeria. We're very happy to have with us today Claire Omoche, the President of Healthcare Foundation of Nigeria, who's just going to give us a sketch of actually what's going on in this country right now. Thank you very much. Claire.
Of course, our wonderful country, green for many things, a very happy place. Told that Nigerians are the happiest people on earth. We are jovial, we are great, we're entrepreneurial, and we are very optimistic. So the green is for a good reason. But we are burdened with quite a few things. But I think most of the world looks at us first as the most populous nation in Africa, with 200 million people, depending upon which stats you use, a growing population which should grow by almost 30 million in the next 10 to 15 years. But if you have a look at that population, about 62% of our population is actually below the age of 24. So we have a young, budding population, which, if they had jobs, would be great. But in the absence of jobs, could potentially be something that I think everybody, every leader, and everybody in Africa needs to have a look at. If we go on further to have a look at the dependency ratio, because we have a lot of children, 14 years and below, and you add the elderly to that, about 86% of our population is a dependent. And that's something to think about from a business perspective. When you think of our life expectancy is approximately 55 years, depending upon where, again, the stats you quote. And this is almost even between males and females across Nigeria. Nigeria is known for a lot of statistics, but I think the one that is most common that we hear, unfortunately, is that we're the second largest contributor to under 5 mortality and maternal mortality in the world. I mean, being 137 out of 140 countries for under 5 mortality is not something that we're proud of, and I think it's something that is giving the government and all of us sleepless nights because we will not be able to get universal health coverage in this way. But of bigger concern is the fact that about 53% of these deaths are actually attributed to malnutrition. So in the last couple of years, you've heard a lot about malnutrition in Nigeria, which has led to stunting growth. Now, those of you that know, stunted growth means that our future leaders, their IQ automatically starts to dwindle, and this is something that is a big concern. So we talk about RMNCH, reproductive nutrition and adolescence, at the end of that big gamut of things that we want to do. Another major concern is that about 60 to 70% of children born in Nigeria are born by unskilled birth attendants. So we have a challenge in getting women coming into hospital environments to have their babies, and therefore we have some of the unsafe birthing stats that you see. Another thing is the fact that 24% of our children have stunted growth. That is a big concern to us. Now, if I come to the private sector and the business environment, As you heard the first speaker say, we do have a few challenges with infrastructure. So power continues to become a big issue. And that's why you see manufacturing in our country could be a whole lot more if we had the right infrastructure, the road networks, and so on and so forth. In addition to that, we don't have any dedicated incentives for private sector. So there's a lot of incentives for agriculture, for telecoms, for aviation, but none at the moment. Now, the Healthcare Federation has been working alongside the government as we speak, and we have a new policy under development with the National Investment Promotion Council. And this will provide some incentives for the private health sector, but I'll talk about that as we go along. Of course, we have very porous borders, and if you are bringing in essential commodities, especially medicines, you'll find out that we also have a lot of faking and adulteration because there's a little bit, it's very difficult for regulation to happen with porous borders. So the cost of doing business has been something that our government over the last 4 years has spent a lot of time and effort in changing. And they've come up with the Economic Growth Recovery Plan. Now, for those of you that are visitors to Nigeria, you'll see that the visa process has shortened. Our airports are a little bit more friendly, and so on and so forth. So I think these are concerted efforts that the government is presently doing, but a lot more needs to be done to be able to open up the sector, make it more easy to do business, and attract more investment into the space. I think also that if you know healthcare, about 60% of the healthcare in Nigeria is provided by the private sector. The infrastructure for that is about 40% of the infrastructure. But we don't leverage enough on the private sector. So when there are a lot of meetings, you find out it's 99% government in the meeting, and maybe, if you're lucky, 1 or 2 voices in the private sector. And I think, again, since the Healthcare Federation of Nigeria came to be in 5 years, this has changed. So we still need to have a voice at the table. And I say to people, if you don't have a seat at the table, then you are lunch. So the choice is yours. We need to be able to get that public-private dialogue going so that when the policies are being formulated, it provides that enabling environment for the private sector to thrive. Over the years, we've had a huge drain on 2 major resources. First, our healthcare workers. It started with doctors about 2-3 decades ago, with them going to Saudi Arabia. And that was called the brain drain. I don't know what to call it right now because we have almost 7 doctors a week going to Canada alone. And so we have a massive brain drain of nurses, doctors, pharmacists. Now, in addition to the brain drain, we have a patient drain. So according to our former Minister of Finance, we lose about $1 to $1.3 billion annually. If you look at our health budget for last year, it was about the same amount of money. So the amount of money we have dedicated as our healthcare budget is equivalent to the amount that is said to be spent on medical tourism. But this can only be worse because the average Nigerian that goes for checkups abroad does not announce this to the government. So what has been captured here is essentially what people have gone to the central bank or to their banks to be able to get affordable foreign exchange.
Minister, a lot of this comes down to money. As I understand it, Nigeria spends less than 3% of its GDP on health. Surely isn't this a time to argue for more money in Parliament?
Yeah, we do argue for more money. We ask for more money and we lobby for more money. In fact, I'm coming right now from a Senate hearing. We also lobbied for more money. But in government, we must also understand that hardly any healthcare system can get all the money it needs. Particularly in our country right now, there are very many competing priorities. The government has to fight with issues of security in various areas. It's also trying to work on creating food security in the country, which was not there before. So there are priorities which we understand the government is compelled to address at this moment, and we hope that as these priorities are addressed, more money will come to the health sector. At the same time, we are looking at mobilizing resources from the private sector. I heard Claire say something very interesting just now. We work with the private sector. We encourage private sector providers and also various groups and organizations who render support to increase the resources available for healthcare.
What about this issue of doctors? We've just been hearing here that many of your doctors are leaving every year to go to other countries. What can you do as health minister to get them back?
Well, we are doing what we can to stop them from going so that we don't have to get them back. But we're also getting some actually who come back, which is good news for us because they come back with knowledge and skills which are badly needed here. We welcome those who are coming back. But many of those who leave the country are also attracted by bigger money outside. I was talking to the postgraduate medical college some time ago, and they told me it takes them about 70 million naira to train one Nigerian postgraduate resident. 70 million. So if you have 10 of these leaving, we are losing 700 billion. So we're actually subsidizing healthcare in other countries, particularly in developed countries.
But my point is, with so much money that's invested in these doctors, isn't it worth the while of the government to make them better off working inside rather than taking their skills to Europe or wherever?
First is to provide the opportunities, and the opportunities right now, the way things are, do not arise for all of them. We are trying to make sure that more doctors are employed. But there are others who, even if you provide the opportunities, think there are bigger bucks outside, and you can't stop them, there's freedom of movement. But as I said, there are others who also come back permanently, and there are others who come back in missions. They create medical missions, they come back for 2-3 months and they go back again, and they do that every year. In fact, we are expecting a group from the UK very soon, of Nigerians who work there, who do missions back home here. I hope I can visit them because they have a conference in London. I hope I can visit them and encourage them in that.
What can the government do to train even more doctors? So bearing in mind, you said it's very expensive to make up for this emigration of your doctors here.
Well, we are not sure that the answer is to train more, but the number we are training now will do, and we want to focus more on those particular specialties where we think we need more people, and create a better disaggregation of the specialists that we have, because there are areas where we actually need more specialists and don't have enough. The investment is not only upwards, but also downwards. We need to train more people for the primary healthcare level. And I was hearing Claire say something very interesting just now about giving nurses more skills, and which we have actually been thinking about. There are places now where very skilled and experienced nurses and midwives are taught to do cesarean operations in areas where doctors usually would not be found. So if you teach them just one type of surgery very well, and they know when to apply that, when to perform that surgery, then you have services that doctors would normally deliver being delivered in rural areas. We want to increase the pool and the skills of our community health extension workers to be able to get down to the grassroots, down to rural areas, hard to reach areas, into the creeks, into the semi-arid areas, into the mountains. And one of the strategies we have is also, if you do not find people to go to those primary healthcare centers, go to those areas and recruit the best you can find, bring them in, train them, and return them to their communities. So that way you can avoid the problem of attrition, because we have a lot of attrition also, even at that level, of people who do not want to work in the most remote areas, but they're employed to go there, and they rather resign, or you have a lot of absenteeism. So getting candidates from those areas themselves and training them and sending them back, we hope will reduce attrition.
My name is Mariana Tiebet, and I'm the lead of MSD for Mothers, which is MSD's global health initiative to help create a world where no woman has to die giving life. And back in 2011, MSD committed $500 million to that effort. I refer to that because of the question, where are we today? We're not where we need to be. If we're going to meet the SDG goals, we need to be working twice as fast and having our money work twice as smart in order to save lives. Because today in Nigeria, at least 200 women are dying every day due to preventable causes during pregnancy and childbirth.
Recent figures that came out this week said something like 200 million children. That's the population of Nigeria. are undernourished, under 5 years of age. I mean, that's a huge problem that not only should be drawing the eyes of governments around the world, but also the eyes of private business as well to get involved. What do you say?
No, you're exactly right, and you're alluding to the interconnectedness of all that we're talking about. So it's not just when a mother survives that her children are actually more likely to survive, more likely to complete their educations, more likely to be well nourished, and that has positive ripple effects on the economy. And positive ripple effects on the economy also improve access to healthcare. So we need to get into this space where we're in a virtuous cycle, where we have inputs going into the health system that improve health outcomes and improve development.
I'm sure people will read the report even more as the days pass. It just was released yesterday. And yes, it's one of those reports that should make each one of us just sit up and sort of look at it very seriously. The issue around undernutrition, we are calling it the triple burden, with undernutrition, hidden hunger, and overweight. And children bear the brunt of this triad, really, because we're not able to provide the kind of optimum nutrition that a child needs at every point in life. And it starts really early on. It starts with a pregnant woman, it starts with the baby she delivers, and then goes on as the child grows up. And of course, we know the first 1,000 days are the most critical, the first 2 years of the child's life. But I want us to, for a minute, look at the story behind the numbers. Because yes, we say 200 million and we get that attention. But behind the numbers, there's another story to be told. And as you bring that number down to a country like Nigeria, where you have millions of children as well that are undernourished, we have one of the highest stunting rates, a high wasting rate, many kids that are not receiving the right nutrition at the right time. We know this. So it's not just about getting the right nutrition. It's also about the food systems. It's also about the surroundings. It's about the community, the family, the mother, the parent, the father. So it takes a whole system, really, to make this happen. But coming back to Nigeria and go back down to the state, to the LGAs, to the wards that we're talking of, to the communities, and go to that one child, and the mother, and the father, and the community. And I think that's where we have to start and get going into what we need to do with these numbers.
Nick, I would say to you, one of the things I've read about this particular issue with mother and child, it's the weaknesses are exposed even more by poverty in this country. We've spoken to the minister, we've heard exactly what he's had to say on that. It must be a very difficult and frustrating job for you sometimes in government, trying to provide healthcare for a multitude of people with very little resources.
Yeah, what you're saying is true, and I think from what the minister said, a lot is being done. But I'll just go back to what is being said about nutrition. We seem to forget that it also contributes, I mean, 53% of that. And we see our young mothers. I've had instances where you see a girl who is 16, she's just had a baby, and she's just mixing some grill because she doesn't understand what is to be done. So that issue of poverty, issue of education, and across Nigeria is so diverse. There are places where, that they don't even have that information as well. So talking about data in Nigeria, there are places that people don't have this, and then poverty is a problem. And if we all put together, I was looking at a particular thing, I'm looking at, okay, why are we stagnating around routine immunization? Why are we stagnating around these indices? It's because we're not looking at other things. We're looking at nutrition, we should be looking at poverty, education, especially literacy level. So if you go to the rural population, the literacy level is low. The poverty is high, infrastructure is there. So all of this is contribute to that same person that needs our care. So I'm believing that with the way the government is going, especially around the basic healthcare provision fund, and also having the ward development committee being part of this and checking off on what is happening, because at the ward development committee, we're now saying it's not only about health. We want education to be there. How many girl child, are being, recruited into schools, because that's why we don't have nurses in some places. What is happening around agriculture? They're talking about those seeds that can give us nutritious food. Are people, being taught? What of community kitchen? How do we learn, how to make that food that is nutritious? So in MPACJ, we are thinking about all this together as we work with the states, as we work with the local governments, and at the facility, even the community level, through the CHIPS program. It is all encompassed within that package that is provided at the household to counsel the mother, to educate them on what to do. Yes, it's not something we would do. Rome was not built in a day, but I think it's a collective effort of all of us to see that we do our best and then see that we deliver to this country country that we call Nigeria that we love so much.
I mean, Marianne, you've heard the minister and you've now heard Nneka talking. A lot of things, yeah, everyone agrees, a lot of things are being done, but is it enough?
It's not enough, and I actually want to come back to the points that have been made again and again about how we don't have enough resources. And I'd actually like to flip it and ask us to really look at the resources we do have. Are we using them effectively? Are we using them efficiently? Are we capturing all of that? There has been a lot of talk today around healthcare worker shortages, focusing on physicians and consultants. But we have huge resources and assets in our communities, even at the village level, that we can use, we can train to serve their families, their friends, their neighbors in their communities. And I just want to give two examples, actually. Traditional birth attendants. We know many women are using them for many different reasons. One of our partners in Cross River State worked with all of the traditional birth attendants to help retrain them to bring women to facilities where they could give high-quality care and use the pre-existing traditional birth attendant networks to also provide counseling and education to women so that they could recognize when they had dangerous signs and symptoms that they would need to go to the facilities. That type of approach actually reduced maternal mortality in Cross River State by 66%. So I want us to look at the riches and the resources that we have, because if we use them properly, we can make a difference.
Building on that and looking, I want to raise this thing about resources, because the minute we say resources, everyone thinks of money. But if you look beyond money, there's a whole lot of things involved in the word resources. And I think that's the crux here. And going back to what you were just saying, Marianne, about assets, really, and that's something we've been discussing as well. We've been talking to different experts in the country. We've been talking with the government on how do we look at the asset-based approach right down at the community level and start moving upwards. To give another example of that is the emergency transport scheme that Nigeria has. And I've seen it myself in some of the states and communities I've gone. You have a network of the transport operators who give their services free and volunteer into the scheme and are able to transfer mothers and babies and children when there is an emergency. But you need to start building on these things instead of letting them be pockets and islands, and bring them up to a level where they can go to scale and they can be sustainable. Instead of constantly trying to do new things, yes, innovation is very important, we must do that, but there is some value in sustaining and pulling along certain initiatives that are showing us results.
Nneka, Marianne raised a good point as well. It's not just about money.
There's a lot of things we have to look at all sides. From the community, what do we do as individuals and what does the government do? Health is on a recurrent, and therefore, yeah, thank you very much. Yeah, so there's a lot, that happens, and you have responsibilities across the various levels. What is the responsibility of the national federal government? What's the responsibility of the state? What's the responsibility of the local government, the committee, and you, myself? What's our responsibility? So it can't come from government alone, and we have to think together. I'm happy to hear the private sector, what they are saying. I would like to hear more about what they are going to do going forward around the primary health care. 70% of our population are in the rural areas. The indices there are poor. What are we going to do together to ensure that we improve the lot of these people? It's not only about health, we're talking everything. We're talking nutrition, we're talking about environment, infrastructure. If we start having roads built, then maybe these nurses will stay there, because most of the nurses are women, and we depend on our husbands. And if we say you can't stay there, come on, if you don't get a good school for your child, you can't stay there. So it's a holistic thing. We have to do all across board. And I think it's a lot for the government and for all of us to do.
Okay, so it's got to be up to us and our colleagues in Lagos and our colleagues around the continent of Africa to start developing the underdeveloped areas right now. Because if we don't do it, ladies and gentlemen, somebody else is going to come and do it for us. So we need to find, particularly in healthcare, solutions that we can partner the best of the outside, bring them in and work with them, and at the same time develop our own uniqueness. That's where the answer is going to lie. Our focus must be on modern technologies. We have got to leapfrog legacy industrial systems. We don't need to industrialize. Let me say that again. We need to technologize. And in Nigeria right now, as a springboard for the rest of the African continent in healthcare, it's got to come from the people in this room. It's up to you, ladies and gentlemen, to work out the best partnerships, to develop what it is that you need for yourselves, and to lead the planet through developing Africa first. And why we do it is then we get our own continent fixed, and beyond that we move our stuff to the outside world, which is ripe and ready for technology now. Okay, 2020 is coming. When you think about it, it's a world that's more connected, more converged, more convenient than ever before. This is where we've got to find ourselves from a healthcare perspective. We've got more connected people. They have a device. Connected people demand more, but they're also more connected. They're more empowered. They're more engaged. They want stuff. And from our point of view on business, we've got to be, with connected things, more useful, more convenient, and more simple for them. It's weird, isn't it? You see, Nigeria used to rely on its oil. Oil used to be the most valuable commodity on the planet. It's data today, bits and bytes, that has become the most valuable commodity on the planet's surface. Nigeria needs to mine data. Nigeria needs to grow and build and then replicate data. That's going to be part of the way forward. You see, there's a new formula for business success. And it intrigues me, really, because the formula for it was quite simple. There's no real magic. There's a basic formula. And that formula for business said, if you understand your past, you can modify your present, and that should give you a sense of future. That worked when the world changed bloody slowly. Today, they're teaching a new thing at MBA school. What they're saying now is, forget about your past. Doesn't matter too much about your present. What matters is your difference, your uniqueness. And your uniqueness will give you a future. You're already unique because you're here. We've got to start building that future cleverly now. And people want more from that future. They expect more, and they're going to come and demand more, from business as well as governments. Everyone needs to understand that. What are we doing in digital healthcare? Because we need to build. And what we tend to do is worry about the wrong stuff. There's no future wasting our present worrying about the past. You can blame the past. Seen that happen a little bit today. Oh, we inherited legacy systems. Really? What are you doing now? Because I can't eat the past. Your kids can't get vaccinated from the past. We can't do cancer tests from the past. What do we do now? We've got to start worrying about our future. And you see, I understand why. I mean, your minister, bless him. Powerful man, ready to do what he can do. We're putting people first in healthcare. I understand that. And it's a massive mission and a huge weight that sits on the man's shoulders. But here's the problem that he experiences, and the rest of us do as well. It's how we get ready to change.
You have been watching CNBC Africa's special highlights of the Future of Health Summit held by Forbes Africa in partnership with Philips. More to come after the break. Do stay with us.
Well, joining me now on the line from London is Dr. Funmi Adewara of Mobi Health International. Just to start off with, in broad terms, where do you see the big health challenges in Africa?
Thank you, Chris, for inviting me over, and I'm very pleased to be here. Obviously, there are tons of articles on the various challenges that people in Africa face trying to access healthcare. From poor infrastructures to shortages of doctors and high cost of treatment, exposure to counterfeit medicines and unqualified personnel. But one of the biggest challenges that we have, one of the major challenges that we have right now is the shortages that we have with doctors. So Africa bears 25% of global disease burden, but is serviced by only 2% of world doctors. And if I must bring this home, I just want to give you a narrative where you see the population of Nigeria is about two-thirds the size of America. And America has 1.2 million doctors. Nigeria has only 72,000 doctors, more than half of who are outside the country, people like myself, practicing in the Western countries. And every year, more than 2,000 doctors leave the continent in search of greener pasture. So that is a crisis situation where you have less than 30,000 doctors to a population of over 200 million.
How do you think technology can help close this tremendous gap you're talking about?
Technology is disrupting the global economy on a very large scale. And from agriculture to aviation to banking, and healthcare has not been left behind, particularly in the Western countries. Over the last decade, we've seen a rapid disruption of the healthcare industry using technology, from wearable devices to AI technology now and blockchain. You have telemedicine where you can now provide clinical care to patients remotely. And so this is a very fascinating development, a fascinating time. And Africa is one of the fastest growing markets in mobile technology adoption. Even those in the rural areas who have no access to phones, who have no access to internet, can still access doctors remotely. We, for instance, Mobile Health International was developed for this sole purpose, to be able to bridge the gap in the shortages of doctors. We have a platform where we have a database of more than 100,000 multilingual medical experts from around the world, particularly from Western countries and also Africa, who provide video consultation to patients through our platform. We have an electronic health record system. We have a video consultation, video software that will enable a doctor in the US, in the UK to consult with a patient in Africa. And there's no language barrier, so we can connect the patient in remote Africa with a doctor in the US or in the UK who speaks their language.
30 seconds, all of you, one by one, just where you see this digital technology space moving in the health industry.
Well, I don't think this is a 30-second answer, so I'll try to do it in 30 seconds. I don't know, and I think that's a good thing. Because if I think about Africa, we all know that access to care and quality of care is a challenge. And the way I see digital is as a vehicle to make this happen. Because in the examples we've seen today as well, is that I think we can basically create whatever vehicle we need to deliver healthcare. And that's how I see digital.
Well, I think where we are is better than where we were 5 years ago. If we look at the continent of Africa, we're finally, I think, in a position where we recognize technology is here, and we better grab a hold of it if we want to be in a different place in 20 years, in 100 years. But at the same time, we are absolutely not where the rest of the world is, and I think we need to recognize that. The rest of the world is talking about extended reality. They've moved beyond virtual reality, and they're looking at how virtual reality interfaces with human reality to actually transform medicine and offer more personalized care. They're looking at how AI and quantum allows them to analyze complex data sets in ways that we're not really doing on the continent. It's taking the rest of the world much further and ensuring that there's much more personalized medicine. But at the same time, there's an opportunity for us to leapfrog, as we keep on saying, in a meaningful way to ensure that we facilitate access to quality care by leveraging technology in a multitude of ways.
At Mobile Health International, we are focusing on leveraging on what the fourth industrial revolution presents to us. We're in a world of IoT, Internet of Things, virtual reality, robotics, artificial intelligence. This presents opportunities for technology companies who are looking to take advantage of these advancements, and also to use it to improve the healthcare sector. So in Mobile Health International, those are the things we're focusing on and using it to, especially our focus on telemedicine to help improve universal health care.
For the most part, the facilities we obviously deal with the paperwork, and they weren't open to technology at first. By the time we actually add that deeper integration with them, we were able to gather data points by the use of data analytics, demand planning tools, and inventory management. We were able to actually forecast their needs, and top of it is that we were able to actually offer them quality access to medication at a very subsidized rate.
Yes, but you're at the head of a section of a large multinational company. You're very much in the leading edge of a lot of these technological changes. What is it that we take for granted now that maybe will be taken for granted in 5 or 10 years' time? What's coming up in this business?
Well, I think we saw some examples earlier that talked about robotics, heart surgery. But if we look at Africa, Philips has made a commitment to work on the SDGs, and we know that mother and child health is part of that. And maybe I can just show and share an example of what we already have today. I represent Philips, so I can also make a little bit of promotion for Philips. We all know that getting an ultrasound scan for a pregnant lady is quite important. And when we talk about access and quality of care, we also know that there are many places in a country where you cannot reach a person for an ultrasound. We also know that ultrasounds are normally card-based. So, and now I feel a little bit like a magician, but I have an ultrasound on me. And that is something that we would not have before. Because now I really feel like a magician. Basically, this is an ultrasound. So the only thing I need is a smartphone. I can plug it into a smartphone, and this is my ultrasound. There are other ultrasounds around, but with the platform on this ultrasound device, I can actually train a healthcare worker, and I can ask him or her to go into the field, and we all now FaceTime. With this phone, I can get a FaceTime connection to a specialist, and he or she can help me. So if you talk about how digital technology is changing healthcare, if you put this in the hands of healthcare workers, they can go into the field, they can do a scan. If they're not sure, somebody on the other side of the world or in Lagos can actually live look and see what is being happened and give guidance. So if this is already possible today, yeah, then in 5 or 10, 15 years, I think we can do much more than an ultrasound.
What is the fear earlier that I raised with the Minister that Nigeria might get left behind because of a lack of infrastructure?
It's a real fear, and I think it's a justified fear. You know, just highlighting what we do at MDoc to really emphasize this. So we started because we recognized that 36 million people in Nigeria alone were walking around with diabetes and hypertension. And we understood if we left the status quo, many of them would die prematurely. Basically, WHO says 20% of Nigerians will die prematurely from 4 chronic diseases. And at the same time, we recognize, okay, well, we have immense mobile phone penetration rates. Why don't we leverage the mobile phone to ensure access to preventative and promotive care to support people in lifestyle modifications? We thought it was pretty simple. We sat down with people, really leveraged user-centered design principles to co-create initially a platform to support them. But then all the real challenges of life came into our reality. So one, the high cost of data, broadband issues, the reality that that a smartphone penetration or mobile phone penetration should never be seen as a proxy for digital literacy. Many of our members will tell us, I have my smartphone, but me, I'm not using it, so just SMS me or call me. I don't want to, unless it's a video or WhatsApp. And so we recognize that, look, we've got to meet people where they are. So we had to then start creating in-person community-based hubs so that we could go to the community, teach people how to leverage our platform, interface with coaches to support them, but also meet with other people like them and learn from peers how to use the phone in that way. And so I think when we think about transformation from a technology perspective, we've got to think about all these ancillary pieces. We've got to think about the fact that even our own staff may not believe that digital is the way. And so we have to train them to motivate the same people who are our end users at the same time.
My take will be, in Africa, we have opportunities. You know, there are opportunities for us to, you know, leverage on what is going on in the world. So I don't believe Africa will be left behind. Even in terms of, look at internet penetration, okay? 5 years ago, we didn't have a lot of that. But now we have everybody having a smartphone. 3G networks are popping in here and there with service providers. So in a way, we are slow, but we are also, you know, gaining traction by and by. And I think in a short while, we'll see better traction and improved services coming to Nigeria, which will help us, you know, increase how we leverage on technology in the healthcare sector.
We see everywhere that there is a new era of technology upon us. This is not so much only in the technologies that we dream of, which are like robotics, but it's also very much on just capturing data on patients. So even systems to better track patients, to better track them through their life can already make a tremendous impact. So what we're doing as Philips is not only to try to look at let's say, the very high-end innovation and the high-end digital solutions, but also trying to see how you can bring solutions, and for instance, a simple patient registering system, to have that at a low cost, at a level that it can be, let's say, installed in a local hospital, operable by the staff, is already very important, because if people move around, they need to take their records. If a doctor wants to see something, he or she needs to pull up the records. And if you talk about medication, if you want to make sure that medication actually ends up with the right patients and the right doses, you also need to check that. So I think the challenge we see, and which at the same time is also a great opportunity, is yes, there is a lot of really high-tech digital work being done, but there is also basic stuff that in the past were very expensive, where you would have to do a very expensive implementation of a software system, where we actually can now do it at a much lower cost. So it also allows you to bring maybe somewhat established old digital technology, but at a very different price point to masses. And I think that's also a very important one. So it's about creating new innovations, driving new technologies and new ways of delivering service, but also ensuring that things that are maybe basic in certain countries, in certain parts of the world, are also available at scale in less fortunate circumstances, less fortunate countries.
Yeah, looking from now, say the next 10 years, obviously the entire dynamics would have changed. But I feel the healthcare space is quite fragmented, and we need to actually do some stuffs at our back end before we can actually, expect, the very best in the future. So we need to fix a lot of things. We need to collaborate with the various stakeholders, and we need to create this ecosystem whereby we bring healthcare stakeholders, government officials. I'm pretty excited the Honorable Minister of Health was actually here, and he exposed us to a lot of realities from the economy. And I think the big thing is effective collaboration with proper healthcare skills. That will basically scale us to the next level.
I think the whole purpose of doing a case study is to show how practically young people can be entrepreneurial, how we can grow our ideas, and how they don't have to remain just ideas. They can actually make a difference in people's lives and be profitable while doing that. So I believe that business is a really big force for good. A lot of people, when they hear business and when they hear profit, think it's something for greedy people and think it's something that shouldn't be associated with healthcare. But I really strongly believe that you can do well by and do well and do good at the same time, and that's what I'm going to talk about. So my speech will just talk about 3 different areas. I'm obviously going to talk about my favorite person, Dangote, and what we can really learn from the way that he's built his business about healthcare. And then I'll be using my business as a case study to talk about some of the plugs, some of the ways that it plugs gaps in the Nigerian healthcare system. Flying Doctors Nigeria, what do? We work across West Africa in all of the countries that you can see here. This is kind of like our catchment zone. And we fly patients within this region. We fly patients within Nigeria. We fly patients outside this region as well for international repatriations as well. And what does that do for the healthcare system? First of all, it's a good source of inbound medical tourism. I'd always say the best thing that the current administration has done is visa on arrival. So we're actually able to bring tourists, American tourists, British tourists, into Nigeria on an emergency basis for the first time ever. And that has meant that we increase inbound medical tourism, both from local people in Niger, in Chad, in Central African Republic, in Congo, in Cameroon, into Nigeria. And that brings Forex into Nigeria as well. But it also allows countries that may not have the volumes by themselves in this region to develop centers of excellence, develop specialized surgical procedures or medical procedures, and then facilitate the movement of patients around the region. Because even if you add up the entire health budget of West and Central Africa, you will not get 1 year NHS budget. So that means if we want to have the same standards of healthcare, we need to look at volumes, number one, like they have in India, and we need to look at price, and we need to look at logistics, because definitely, if you look at the prices of constructing hospitals, it's between 100 million on the low end and $1 billion on the high-end hospitals. So we're not going to build 1,000 of them in West Africa. We're not even going to really be able to build 100 of them in West Africa. But what we can do is have a few specialized centers of excellence, and I know that ECOWAS is working on this now, to introduce these high volumes into centers of excellence to increase efficiency and to drive down cost. It also creates a lot of jobs, because when doctors get specialized and they're more productive, because the Indian doctor is more productive than the American doctor, you can start paying these doctors more. In terms of economic growth, this is great for several industries. It's great for the airlines, it's great for the ground ambulance services, it's great for the airports, it's great for the hospitals, it's great for the insurance companies, because they can be more decisive about where they send patients for better care as well. In terms of centralization, it improves quality, because more centralized procedures actually have far better outcomes according to the evidence. And it also helps to reduce brain drain, because these doctors can earn extra money by working on the air ambulance, the specialists can earn extra money by working on the air ambulance, and it's something exciting, you're getting on a plane, you're flying around West Africa. Interesting work keeps doctors in West Africa. So, the aim of every healthcare policy, every healthcare intervention, is to improve quality, it's to reduce cost, and it's to expand access. And I hope that I've given you some kind of idea about how you can innovate in the healthcare sector profitably to do that. Thank you very much.
The current thing is to make sure that everybody is covered. We talk about health for all, we talk about universal health coverage. And basically, when you talk about a country that has 200 million population thereabout, and 90% of that population is not covered, you're going into crisis, one form or the other. That means your health system is in disarray. And one of the things that can come out of such a chaotic system is all sorts of things, And in terms of maternal mortality, child death, and infant mortality and all that, those things will keep coming and they will keep dogging your system, because in terms of quality of care, people are not getting it because the population level doesn't have that access to the kind of quality of care they should have ordinarily to be able to stem some of those indices that you have in your system. So we can talk all the things we want to talk, but basically the whole idea is that we should be very strong in our weddings in trying to pull the poor out of poverty, because if we don't pull them out of poverty or give them some level of financial risk protection in getting or access to healthcare, there will be problem. And like somebody mentioned there, the largest population now, young population in the world, is in the Sahel belt. And about 8 states or 9 states in Nigeria fall within smack in the Sahel. And that population is also growing every day. The rate of childbirth in those areas are very high. I remember in Sokoto State, at a point, Sokoto State had about 93% of women who were delivering at home. And some of them were delivering with no one present. And you can imagine if a woman is delivering alone at home in a rural area and she starts bleeding, what do you think the outcome will be? So when we talk about these things, we need to really see what the realities are on ground. And they are not this thing. But then, on the flip side, like a lot of people have said here, is an opportunity. It's an opportunity for private sector. We looked at the Sahel, and most of the countries of West Africa, 15 of the ECOWAS countries, need around, between now and 2025, they need roughly around 700 million to invest in their health system to be able to have the modicum of care to take care of their people. And if you look at that number, Nigeria constitutes about 20% of that. And so that's an opportunity in itself. It's an opportunity for investment which doesn't have to depend on public sector. It has to now leverage on the advantages of private sector investment. And the private sector has to be very innovative and disruptive in the way it approaches it. So I think those are the ways to look at it at the moment.
Now, Adesimbo, you're a member of quite a small group in Nigeria. You're an investor in a private health company, of which, from what I'm hearing today about the state of health in Nigeria, there's not enough of them to fill some of the gaps in the public health system. Why are there so few of them?
It's quite a good question. I mean, we are on the side of demand. So what we do is provide financial access to people in order to enable them access healthcare services when they need it. We're a private health insurance company. To operate in that environment, you need to have people being able to pay to contribute to the pool. You know, in a country that has about 46% living at or below poverty level, that's very hard. You know, right now when we talk about coverage, we don't even seem to realize that more than 90% of that coverage comes from federal civil servants who are paid for by the federal government. You know, the population of Nigerians who are covered under private health insurance is far, far, far less than what we think it is. You know, so the market is not really as of yet large enough to provide a real investment rationale for people who want to come into this line of business. One of the most pressing things I think as a country on a larger level we need to address is this issue of poverty and unemployment and all of that will enable people to have an income from which they can contribute to a pool. But also financing and providing subsidies for the less vulnerable people and the people who cannot afford, you know, to by themselves pay and make contributions is something that the government needs to look at quite urgently. But even sadder is the fact that, you know, in the private sector now, there are so many individuals who work for themselves and small and medium-scaled enterprises that are also not covered because insurance is not compulsory. I mean, that's what is most disheartening. You have somebody running a business, employing up to 10 people, 12 people, 20 people, and there is no form of insurance. Some of the larger companies also don't provide that health insurance coverage. So the Health Insurance Commission bill is something that we are looking forward to, and when that is passed, we believe that it will give a rationale, put some incentive in there for people to come more into the sector, serious investors to come in and invest in the sector.
Francis, if I come back to you now, this health insurance bill has been talked about several times today. How could it change the game for the health system and also private health companies?
Yeah, but I mean, it's like I said, one, you look at it from the side of the people, because for us, anything we are talking about is about the people, and vulnerability is one of the critical issues. A large chunk of Nigerians are living under poverty, like she just mentioned. So if you have some modicum of health insurance that covers them, you are likely to have more money in the pool in terms of financing health in the system, whether for private or for government. And one of the things I need to mention here is that there have been talk, even when the minister was around, about the Basic Healthcare Provision Fund. I was part of development of the National Health Act from 2003 to 2014 when it was passed. The basis for that fund was catalytic. It wasn't meant to be a cure-all. And the money, if you divide it across all the active primary healthcare centers in Nigeria, you'll probably have something close to 150 or 200 thereabout per primary healthcare center. So in itself, it is not such a big fund, you know. But the idea is that it should give some level of cover for vulnerable groups. And then state governments need to put into this, and that is where an opportunity lies for private sector, to work with states and make sure their policies at state level that enable them to be able to play in that level, especially in primary healthcare and secondary level, like the minister pointed out. Those are the opportunities that are there. And the opportunity is massive, but the enabling environment has not been such that it has given that. And one of the things, like she mentioned too, is the fact of making it mandatory. Because Nigerians are the issue of health, Nigerians don't take it seriously. The average Nigerian doesn't think of health until he gets sick. And when he's down, he starts thinking of pastor, babalawo, or somebody else before going to the doctor. So when I was in clinical practice, I mean, it was last case for most times. By the time the patient comes in, the patient is almost out. So you find out that mindset is not the same. My good friend Nneka was talking about health promotion and all that. One of the things that private sector can also do with digital technology is health literacy. It has gone beyond just health promotion. People have to, at their level, be able to understand health, because it will improve uptake of services, and then the mindset, the health-seeking behavior will also improve. Without that, it's a problem for all of us.
How much of an opportunity is being missed here? I mean, in some ways, it's the chicken and the egg, in the fact that in other countries like South Africa, the private health sector pours millions and billions into building health infrastructure because they've got this tremendous market. And that's what Nigeria needs right now, and yet most companies like yourself are not big enough to do that sort of thing yet. Well, how's that going to change?
It's You're right that it's a chicken and egg situation because on the one hand, we say that, when we have enough people contributing into these risk pools and when we have, large population subscribing to our health plans, then we are able to guarantee a consistent source of revenue for hospitals and healthcare facilities, and they can attract funding, they can expand, they can, but I think the investment needs to come in at both ends. I think it's, it really can't be one side waits for the other. I think there's got to be a way to look at both ends and try and encourage investment in service delivery, as well as investment in the mechanisms it takes to pool resources together and to pool the funds and the risks together to make, access something that everybody can enjoy. But also more important, we've talked a lot today about technology, and I want to to touch on that a little bit. I don't think enough attention is being paid to technology and how technology can really help to mitigate some of the constraints that our economic realities, confronts us with. Right now, there's really not been much done in order to make, the entire healthcare value chain interconnected. Even hospitals on their own don't generally have a lot by way of, electronic medical records. They are not connected to the health insurance. We are all not connected to regulators. The Federal Ministry of Health doesn't have visibility on what we're doing, and if we all agree that data is the future and we all also understand the kind of insights and the kind of really, really great strides we can make with the insights that we gather from this data, then I think much more needs to be done around that as well, and just getting the entire industry to move in that direction.
Conversations at the Future of Health Summit revolved around exploring challenges within Nigeria and Africa's health sector, as well as proffering solutions, which included leveraging on technology to advance the future of the health sector, public-private sector partnership, and providing access to funds. This has been the CNBC Africa special highlights of the event. Many thanks to you for watching.